Hello and welcome to our first Facebook Live session on testing. Thank you for joining us. I'm Ashley Shaw, Medical Director of the Trust, and I'm joined by Mike Weeks, who is a Wellcome Senior Fellow and Infectious Diseases Consultant, who has worked on many aspects of the rollout of staff and patient tested, and also by Giles Wright, Associate Director of Workforce and the Trust's lead on staff health. So welcome to both of you. The purpose of today is to give you an opportunity to ask any questions you have about testing and set out where we are as a trust in organising this for our staff, our patients, and we'll also touch on the campus facility that will enable much more widespread community testing. Testing is a hugely important issue here for a number of very different reasons, not least of which because it is a critical part of our strategy to manage with COVID-19 in our communities and hospitals for the foreseeable future. We've received a number of questions ahead of time from staff who aren't able to join us live, and we'll try to get through as many of these as we can in the next half hour. The recording will be made available to colleagues after the session. So if we go through some of these things in order, the first thing we're going to talk about is patient testing. So we've moved a long way in terms of our capacity to test our patients using the swab test, followed by PCR analysis of samples. As of this week, from yesterday, we have been swabbing all patients who are being admitted to Addenbrooke's and the Rosie for any reason, whether that's elective or non-elective procedures. Anyone who's having an overnight stay or who's coming in for an operation will be swabbed. That also includes patients who are coming into the maternity unit. So that's a huge step forward. In addition, I'm very pleased that from tomorrow, we will be also able to offer antibody testing to all patients coming into the hospital. And that will enable us to build up a picture of those patients who have been previously exposed to COVID at some stage and who have mounted a response to their antibodies. The usefulness of this in real time will be difficult to know at first, but I think it's important to start to be able to get the testing in place so that we can build our understanding and our knowledge of this disease so that we can then start to guide our management as we go forward in the future. And I'll hand over to Mike to talk to you about our current situation with regard to staff testing.
Thanks, Ashley. So in terms of our staff testing programme, it's been running for just over 3 weeks now, and we've actually got two different streams of testing people. Firstly, one we call the asymptomatic stream, where we go through a series of different wards and test people actually in situ on the ward. The way this works is that someone will deliver a group of swab packs to the ward, and then people can collect their own pack, swab themselves. It'll be delivered to the lab and the test will be done there. And when I say the lab, this is actually being done by Steve Baker's lab in Cambridge Institute for Infectious Diseases and Therapeutic Immunology, who's been really helping out with this from the research angle. And we found actually reassuringly so far that a small percentage of staff in this category are actually positive for COVID. And these split into 2 or 3 groups: people who genuinely have no symptoms whatsoever, which is a very small percentage, less than 1%. People who have previously had symptoms suggestive of COVID, have appropriately self-isolated and still test positive. And they still test positive for residual genetic material from the virus, but there's evidence that you don't continue to secrete virus after 7 days after you've been unwell. And then there are some people that have had relatively minor symptoms like a slight headache, a minor sore throat. And we know that some people like that, again, a small percentage, less than 1%, will test positive. And we've noticed a few of them. And we've tested more than 1,000 people in that category so far. And we're rolling out through different wards, particularly where there's a higher risk of exposure, such as red wards. Obviously, there's very good PPE to be used there too. Then there's also a symptomatic stream, and for people with symptoms, you can phone up occupational health. So far, we've chiefly tested people with what we call high probability symptoms, such as a fever and a prolonged cough. However, this is being extended to people with certain other symptoms, such as flu-like symptoms, in a rolling manner as well. Our capacity for testing at the moment is so far we're testing up to about 200 people a day, and we're planning on increasing that to about 300 a day, so that we can encompass on a rolling basis all of the wards we're particularly interested in, and are hoping to cover many of the hospital wards, and also all the people that have symptoms on a daily basis. As I say, so far, people who've had no symptoms or minor symptoms on the wards, a very small percentage of people have tested positive, in total less than 3%. And the percentage of people with high probability symptoms, if you have a fever or a prolonged cough, that have tested positive is less than 20%. And that's consistent with other studies. If you have fever and a prolonged cough, then obviously that's more likely to be COVID.
Okay, thanks very much, Mike. So we do have a number of questions that have already been submitted to us in advance of the meeting. So I'll just go through those in order. So the first of these is in relation to staff testing. Giles, will all staff be tested for COVID-19, whether they are symptomatic or not?
As Mike's already answered to some extent, so if you're symptomatic with either the symptoms described as COVID or flu-like symptoms, then absolutely we will offer you a test. We ask that you call the occupational health team on day one, certainly in less than 5 days since the onset of symptoms, and the team will triage, assess, and then book you into one of the pods which are situated outside of the S block on the campus. If you're not experiencing symptoms, as Mike said already, you are potentially eligible for testing or will be picked up in the testing programme, particularly in areas where we have reason for potential transmission or concern, where we're seeing outlying levels of sickness, which may be related to COVID. We're targeting samples of staff on those areas for assurance purposes, really, to explore those issues and concerns.
Okay, thank you. And second question on staff testing, Giles. We have some staff who have worked on wards where patients were treated and subsequently found to be COVID-19 positive. Some staff on those wards have been tested, for example, the usual pharmacist on the ward, but not another pharmacist who also was present on the ward. How do we go about getting these staff tested, please?
Yeah, absolutely. So, as I say, where we're targeting a particular area, we will initially do a sample of staff, usually a given shift, working pattern, to just see whether there's any trends or results that give us further concern. If we do identify positives, then we will look to screen all of the staff that are on that given area or have been in contact in that area, such as pharmacists and other staff that roam between wards. Where that work's happened, we've got confidence that we've picked up most, if not all, of the staff. However, if we have inadvertently missed somebody and you believe you're in that category, please do contact occupational health as soon as possible, and we will, of course, make sure that you're tested.
Thank you very much, Giles. Mike, one more question on staff testing. So are you able to confirm whether or not the testing that CUH are carrying out will identify people who have had it?
So the short answer is no. Essentially, it's a test for the viral genetic material by a swab from the nose and throat. And so it will tell you if you have it at the moment or if you've had it within the last 3 weeks on average. Some people, you can isolate the genetic material for a bit longer, maybe up to 4 weeks, but it's not a test as if you've had it any time in the past, like an antibody test would be.
Okay. And moving on from there, as a question I think I'll take myself is, will the antibody/immunity test be available to staff? If yes, when is this likely to happen? Well, there are a number of groups around the campus working within the NHS and the university who have developed antibody testing to COVID-19. At the moment, we are in the process of validating some, and we have validated others already. That's why we're able to move for patients to be able to offer that test tomorrow and thereafter. However, for staff, we are also working through the logistics of how we would manage to test 11,000 permanent staff, and a significant number of further staff who work with us through the bank. So we're looking at the logistics of that and how that might work, from actually taking those blood samples and processing those blood samples in a timely fashion, and how we might use that data to try and generate population level knowledge and to try and improve our way of working within the hospital. So hopefully within a few weeks we'll be able to start rolling that out. I think if we consider the speed at which things have moved over the last few weeks, that's a reasonable time frame, and so we hope to be able to give further news in the near future. Okay, so one more question on staff testing. How do you plan to test those staff who work off-site in dialysis units or in the community, Mike?
So the dialysis unit on Newmarket Road is already on our list of places to test, and again we'll simply be delivering packs of swabs for staff working there in a shift pattern, say 24 hours, so that people can self-swab in situ, and then we'll collect them and take them back to the lab. In terms of the community, well, that's a bit like the group that we call rovers who work around the hospital, people like radiographers or phlebotomists, and that group of people we asked to come into the pods on certain Mondays so that they can be swabbed in the pods, because it's very difficult to get everyone collected in a single location. And so, for example, community midwives we might ask to come up to the pods on a given Monday so that we can swab people there.
Thank you very much. So I think we're moving on now to questions around patient testing. So please can you tell me where we obtain the COVID-19 swabs, how we swab the nose and throat, and how we order COVID-19 tests?
So the nose and throat swab is a very simple procedure. It's a dry swab that you swab the back of your throat with. Again, if you're coming in for healthcare worker testing, we have an information leaflet that shows you exactly how to do it. For the healthcare worker test, we actually do a single swab, whereby you swab the back of your throat first, and then you push the swab into your nostril, basically as far as it will go back, and swab around there. And you can order the test on Epic.
Okay. Another question on patient testing. So someone would like to ask the reason that patients are treated as negative without symptoms. The news has been reported that many other countries are treating all patients as positive until proven negative, which I would have thought is a better way to minimize cross-infection and contamination. Okay, so I guess in an ideal world, everyone would be treated in a side room on admission to hospital until we were absolutely certain whether someone was positive or negative. And that would be a combination of whether they had symptoms, whether they had PCR testing, and a period of time in which given things to develop. However, that's not the system in which we live, the world in which we live. And so what we are doing is moving to obviously to test everyone as they come in. We are patients who have symptoms that could relate to COVID-19 are treated initially on an amber ward. They undergo testing, and after testing, they are moved based on their symptoms and their PCR test to either a red or a green ward for further treatment. Similarly, those patients who are being admitted as green will be admitted to an assessment ward. They will have their swab, and then they will move on after that to either red or confirmed green wards. The precise nomenclature may change, but in essence, we are doing our best to minimize the admission of patients to hospital who are positive for COVID-19. All elective patients coming in for surgery in particular are undergoing PCR testing 48 hours in advance, and then being asked to self-isolate for 48 hours, again, so that we can minimize any admission of patients to hospital with unknown COVID. Okay, so those are the questions we have on patient testing. And now a question with relation to the laboratory. So in relation to the laboratories that we're using outside of Addenbrooke's, so over in the University of Cambridge, in these laboratories, could we understand what actions have been taken to demonstrate safety of patients, the reproducibility and accuracy of results? Mike, I think if you want to comment.
Yeah, that's an important question. So, as I say, this is performed in Steve Baker's lab in the University of Cambridge and is being converted specifically for this purpose. But the assay that's being used there is based on the assay that we use in Addenbrooke's Public Health England assay that's actually been improved by Martin Curran, who works in the department, so that it's more sensitive and specific for infection. And so the assay in Steve Baker's lab is almost identical. The difference is that actually when you have your swab taken in the pods or on the wards, you put your swab into some viral inactivation buffer, which inactivates the virus completely, so that it means we can then get it through onto the machine quicker. In the virology lab here, it's not inactivated, and so it has to go through something called a category 3 facility where you have to take more protective actions to prevent yourselves from being infected. But otherwise, the basis of the assay is identical, and it's been validated extensively at the beginning of testing against a group of negative and a group of known positive samples. And so, yeah, it's essentially the same assay.
Okay, thank you. So those are all the questions that have been submitted in advance. Before we go on to the questions that have come in during the broadcast, I just want to talk to you briefly about the laboratory that's going to be opening this week on the campus at the Anne McLaren building on the back of the campus near the bridge over the railway. So you'll be aware that the government have opened 3 lighthouse laboratories in Milton Keynes, Alderley Edge and in Glasgow for mass testing of key workers across the country, and with a stated aim from the Secretary of State to achieve 100,000 tests per day by the end of April. So in response to that, 3.5 weeks ago, the AstraZeneca, GlaxoSmithKline and University of Cambridge executives got together and put together a proposal to open a laboratory in Cambridge to contribute to that facility, to that aim. And very rapidly, using University of Cambridge building, the Anne McLaren building, and the expertise from those other companies, they've put together a laboratory which will open on Thursday of this week. The laboratory has undergone its visit from the Department of Health and Social Care to say that it's okay to press go. They'll be doing some final validation tests this week, and as I say, the first samples will go live on Thursday. The aim is to start with about 4,000 samples a day and to ramp up by mid-July approximately to about 30,000 samples a day. This has been obviously quite a remarkable undertaking from those companies who've never previously tested for this before, and it will be entirely staffed by postdocs from the University of Cambridge and from some staff from AstraZeneca and GlaxoSmithKline. And so we've been working very closely with them to help deliver this. Okay, so, but as I say, those tests will be for key workers around the country, though those will not be used in the first instance, at least for patients or staff at Addenbrooke's. Okay, so I'm going to hand over and you'll hear offline some questions coming in from the audience.
So we've got one. What is the process for testing patients prior to face-to-face, urgent outpatient and pre-surgery appointments?
Okay, thank you. So if I could just take that in 2 phases. So first of all, prior to outpatients, there is not currently the facility to be able to test everyone prior to an urgent outpatients. And so in that instance, we would anticipate everybody taking the appropriate PPE precautions and treating the patient appropriately. When we talk, we are currently thinking about how we open up the hospital to outpatient procedures that may or may not be aerosol generating. And again, that's going to be very challenging. And we're working through that with the clinical directors, the divisional directors, and the nursing teams to try and understand how we might move to a new normal in this COVID state. And finally, with respect to surgery, all patients who are scheduled to undergo elective surgery are undergoing as part of their preoperative planning are being swabbed 48 hours prior to surgery, so that their result is available beforehand. Thank you.
Another one is, how long does it take for results to come back?
Giles.
So for staff testing, we're getting results within 24 to 48 hours consistently, which has been great. In fact, they've been getting quicker as we've gone, even with the volumes increasing. And then positives, the staff members with positive results are contacted by the infectious disease team straight away. And those that are resulting in negatives are being contacted by the occupational health team as quickly as they possibly can, but that can be a day or two before they get contacted.
Thank you.
No others have come through on the Facebook Live.
Okay, thank you. So with that, we'll close the session. So thank you very much for listening in today and watching. If you have any further questions, please email comms@addenbrooks.nhs.uk. We'd love to hear if this has been useful to you. So please comment about how you found the session and let us know if there's anything you could think that we could improve. So thank you all for what you're doing to keep yourself, your colleagues and your patients safe at this time. Thanks to Mike for coming today, and thanks to Giles, and thank you for watching.